There's numerous pieces of equipment that are required to place an ultrasound-guided central line or an ultrasound-guided central line and pacemaker. This equipment includes, obviously, an ultrasound machine, ultrasound gel. Some of the other equipment, a triple lumen kit, if you're planning on placing a triple lumen. With the triple lumen kit, you're going to need 3 saline flushes. You're going to need interlink connectors as well, okay? If you were going to place a cordis for the purpose of a pacemaker, transvenous pacemaker, you would need a 6 French cordis kit, 1 saline flush, and an interlink connector. You would also require a pacemaker wire, an ultrasound probe cover, sterile gloves, a sterile gown, also some goggles and a mask, not shown here, sterile drapes, a pacemaker generator box, some cleaning solution, and also the wire to connect the pacemaker wire to the pacemaker generator box. You would also require a LifePak defibrillator as well. So for the purposes of this video, we're going to assume that our patient is already draped and has been cleaned as well, and is also in Trendelenburg position to maximize access to the internal jugular vein. Our kit, the 6 French cordis, is open in front of us here. I'm just going to talk about the parts of the kit. I've also added on some Huck towels, an ultrasound cover, an interlink connector, a saline flush, a pacemaker wire as well. Inside the cordis kit, you have some sterile drapes. You have the introducer wire. You have a basin for cleaning solution, suture material, a scalpel, the needle, and syringe with which you're going to puncture the internal jugular vein and thread the wire. A pacer wire cover, and the cordis with introducer. Before starting the procedure, you want to set up your tray so it's ready to go. First, you're going to take the introducer, or pardon me, the dilator, and place it through the opening on the cordis. Next, you're going to replace the cap on the end of the tubing of the cordis with an interlink connector. You're going to remove the cover for the introducing guide wire and load it inside. If your patient requires freezing, that can be done before proceeding with the procedure. You would have an assistant hand you the vascular probe of the ultrasound, over which you would place the ultrasound probe cover. You're going to take the ultrasound probe cover, stick your hand through it like a sock puppet, then you will actually grasp the ultrasound probe from a non-sterile assistant and slide the probe cover down along the probe to keep it sterile. What you want to do is find the internal jugular vein on the ultrasound probe and center it in the middle of the field on the ultrasound screen. Once this has been done, you're going to want to take your needle and syringe and access the internal jugular vein. You will note on the screen the bright white area is the tip of the needle. I'm going to slowly advance the ultrasound probe until I lose it, and then I'm going to come back until I can see it again. I'm going to walk the ultrasound probe and the syringe together until I've actually punctured the vessel. Once you actually have punctured the vessel, you can stop with the ultrasound machine. Next, what you're going to do is thread the guide wire through the hole at the base of the syringe. Once the guide wire is in place, you're going to remove the needle and the syringe over the guide wire, leaving the guide wire inside the neck. The next step is to make a nick in the skin over the guide wire. After this, you want to take the cordis and the dilator and slide them both over the wire at the same time. It's important that the wire comes out of the end of both the dilator and the cordis before advancing into the patient's neck. You want to advance the cordis and dilator together into the patient's neck. At this point, you want to remove both the guide wire and the dilator together at the same time. Once that's done, you want to draw back, or sometimes it will leak out the blood from the internal jugular vein, replacing the interlink. At this point, what we would do is we would flush the interlink. I will not be doing this for the purposes of this demonstration because it can damage the mannequin. After this is in place, you're going to want to suture the cordis to the patient's neck. So next we're going to open the pacemaker wire. Inside the container, you will notice a syringe, the pacemaker wire itself, there's a balloon on the end which I'll show in a moment, and two other connectors. You need to remove the new connectors and place them on the pacemaker wire. They essentially slide into each of the black endings on the pacemaker wire. And there are two. You will note on the pacemaker wire there is some writing. There's proximal and distal. This is important to remember because when we hook it up to the connector, the proximal port needs to be attached to the positive attachment on the pacemaker wire. Next, you want to attach the syringe to the port on the pacemaker wire. The syringe should be opened. Screwed on as so. Now, you're going to take the pacemaker wire out of the container. At this point, I like to ensure that the balloon on the end of the pacemaker wire is able to be inflated. And it is. Make sure that the balloon inflates on the pacemaker wire. A crucial step now is to make sure that you place the pacemaker wire cover on the pacemaker wire. If you forget to do this, it's going to be impossible once it's inside the patient itself. The gray end with the small hole goes over top of the end of the pacemaker wire. It then slides all the way down to the base of the pacemaker wire and will click on a little bump at that point. You will also notice on the pacemaker wire itself there are small lines. Each small black line represents 10 centimeters. Once we get to a thickened black line, that represents 50 centimeters. At this point, you are going to hand the syringe and the pacemaker wires to an assistant. You'll note on the pacemaker wire there is a positive and a negative pole. You insert the end of the pacemaker wire onto that area, proximal going to positive, distal going to negative, and then you tighten the pacemaker. At this point, you're ready to insert the pacemaker. What you're going to do is you're going to, with the balloon uninflated, put the pacemaker wire into the end of the cordis. You'll note now that we are at 10 centimeters. You're going to advance the pacemaker wire to a depth of 20 centimeters. At this point, you will ask your assistant to inflate the pacemaker balloon. Balloon up. When you are moving forward inside the patient, the balloon should always be inflated or up. If you are ever pulling back or going out, the balloon should always be deflated or down. Once the pacemaker is on, you will be looking at the monitor to see whether or not you're actually having spikes on the pacemaker monitor. You'll note on the rhythm generator that we have a patient in a 3rd degree or complete heart block. What we should note when the pacemaker is inside the patient is you will note now that there are pacemaker spikes, and occasionally they may capture a QRS, but not always. We know that the pacemaker is then not in far enough. As we're advancing the pacemaker, we should get to a point where should have a pacemaker spike followed by a QRS complex every single time. We know at that point that we are having electrical capture. You can check the patient's pulse to make sure that we're also having mechanical capture as well. It's important to note the depth of the pacemaker wire at this point and record that. At this point, once you have mechanical and electrical capture, we can deflate the balloon or balloon down. Next, what I'm going to do is cover the pacemaker wire with the pacemaker sheath. You'll note on the end of the cordis, there's a small bump. There's also an opening on the cover as well that will go over the bump and lock into place. Now we know that the pacemaker wire is covered in a sterile way. At this point, once we have electrical and mechanical capture, we will ask our assistant to decrease the ventricular output, or MA, until such time as we lose capture on the monitor. So we'll continue to go until we lose capture. Now you will note that we have lost electrical and mechanical capture. What you will ask your assistant to do is to increase the output, or the MA, on the pacemaker generator box at least 2 ticks. At this point, we should regain both electrical and mechanical capture. Please note the pacemaker settings, including rate, distance inside the patient, and the MA, and at this point, we can now place a dressing over the cordis and attach the pacemaker generator to the patient's bedside. So next I'm going to demonstrate the insertion of a triple lumen central line catheter into the internal jugular vein using ultrasound guidance. Here's the kit that we have here. Inside the kit, we have a number of drapes. I've also pre-placed on here some huck towels and some other drapes. I also have 3 interlink connectors, some saline flushes. Inside the kit, we have a dressing, some gauze, syringe, suture material, a needle driver, some syringes with needles for the possibility of freezing. We also have a scalpel, a dilator, an introducer wire. I will remove the cap on the introducer wire. You'll note that it's curved at the end, and place it back inside the sheath. We also have the triple lumen catheter. There is the white or proximal port, the red or brown distal port, and the blue medial port. Before going forward, what you want to do is remove the caps from the end of the triple lumen and replace them with the interlink caps. I tend to leave the distal red or brown port open because that's the one that the wire is going to slide through. Next, you're going to locate the internal jugular vein on the ultrasound machine, center it in the middle of your ultrasound screen, place the needle into the patient's skin, watching for the bright wiggling thing on the ultrasound screen, puncture the vessel, and wait until you're drawing back fluid. Second here, sorry, this one. Once fluid is drawing back, you know that you're in, and you can stop with the ultrasound. What you're going to want to do next is to advance the wire either through the end of the syringe, or you may remove the syringe and thread the wire directly through the needle into the patient's neck. Next, you're going to want to remove both the needle and the syringe, leaving the wire in place. You're going to want to make a nick on the skin. I'll go on the wire. Then you're going to thread the dilator over top of the wire into the patient's neck. You're then going to remove the dilator, leaving the wire in place, to introduce the triple lumen. Once you have the triple lumen, you're going to slide the end of the triple lumen over the wire until you see the wire coming out of the end of the distal red or brown port. You're going to insert the triple lumen all the way into the skin, making sure not to push the wire in. Next, you're going to pull out the wire from the skin. At this point, you may have flow back of fluid from this area. If you do not, what you want to do is to draw back on a syringe and aspirate some fluid. Once that's done, you're going to remove the syringe, place an interlink on the end of that port. With each subsequent port, what you're going to want to do is to flush each port. And note there's a small locking mechanism as well. What you want to do is attach the flush to the end of the interlink port, flush the port, and once it is almost all the way through, lock the port. You're going to do this on each subsequent port. So again, screwing on the syringe, drawing back to get fluid. Once that's done, removing the syringe, taking a flush, screwing it back on, and then flushing the port until it's all the way through, and then locking. Lastly, the blue port, drawing back, taking a flush, putting it on, flushing it through, locking when it's done. Once this is complete, you can suture the triple lumen to the patient's skin, apply a dressing, and your procedure is complete. When accessing any vein, in this case, the internal jugular vein, you want to have your area of interest centered on the ultrasound screen. Then you want to place your needle in the center of the ultrasound probe. You can see the tip of the needle as the area that's white that's shaking near the top. You then want to slowly advance that needle, seeing where the end of the needle is, until it punctures the vessel. Now, you should actually feel a loss of resistance on the syringe. You can confirm that you are in the right position. In the longitudinal view, you can see an area wiggling in the middle. That's the tip of the needle, ensuring that you're in the proper position. Sorry, I thought that guy would never shut up. I just want to demonstrate the use of the new pacemaker generator. Most of us are familiar with the old generator, which just had 3 knobs. This one is a bit more complicated. To begin with, you need to remove the cover of the pacemaker generator. To turn on the pacemaker generator, in the top right-hand corner, there is a green button. You need to press and hold that button until the lights start turning on the generator. It takes a couple moments for it to boot up. You're going to notice 3 dials on the top half of the pacemaker generator. The first one deals with the rate of the pacemaker generator. It can be decreased or increased as needed. I would suggest setting the rate of the pacemaker higher than the patient's underlying rhythm if you're treating a bradydysrhythmia. The second knob deals with the atrial output. In this case, and for most cases in the emergency department, you want to turn this dial off. And that's going to be turning the dial all the way to the left or counterclockwise until it is 0. The reason that this is important, if you forget this step, you will not be able to adjust the sensitivity of the ventricular output. The third dial is the ventricular output. I like to turn this dial to the maximum all the way to the right. Now, when we next get to the bottom screen of the pacemaker generator, you will notice that we are now in VVI mode. We want to select the arrow or selector button to be able to adjust the sensitivity. If you turn the knob all the way to the right or clockwise, this will provide maximum sensitivity for the ventricular pacemaker. If you turn the knob all the way to the left, so the numbers are increasing, the millivolts are increasing, eventually it will get to asynchronous pacemaking. All the way to the left is asynchronous, all the way to the right is maximum sensitivity. So if you have a pacemaker spike on a recovering ventricle, there's a possibility of developing an R-on-T phenomenon and making the patient sicker. By using maximum sensitivity, you could avoid this particular problem. However, the amount of energy being used to pace the ventricle, the likelihood of this happening is small. Once you've attained ventricular capture on the pacemaker, you want to slowly decrease your output or your MA. You want to decrease the MA until you lose capture, and then 2 clicks higher, and leave the output at that particular point. If you have not made any adjustments to the pacemaker generator in approximately 30 seconds, the machine will lock at its current settings. To unlock it again, you need to press the lock key, and then you're back to where you were. The giant red button in the middle with the DOO, don't press it. If you press this button, you will explode and die, which is similar to what will actually happen. So if you do press it, the pacemaker reverts to maximum output, both atrial and ventricular. If you accidentally hit this button, what you want to do is to hit the green select button, which will then take you back to the original screen. However, now you will have to again turn all the atrial pacing off, and then you can readjust your sensitivity to either maximum sensitivity or asynchronous, depending on your preference.